Hello, and welcome to the latest CSF podcast on axial spondyloarthritis. We will be bringing you new episodes on a bi-monthly basis alongside our psoriatic arthritis podcasts, and we will also be supplying you with monthly slide decks to help keep you up to date with the latest research and publications in the field of axial SPA. First of all, allow me to introduce myself. My name is Atul Deodhar. I'm a professor of medicine and medical director of rheumatology clinics in the Division of Arthritis and Rheumatic Diseases at Oregon Health and Science University in Portland, Oregon, USA. Joining me today is Professor Xenofon Baraliakos, professor of internal medicine and rheumatology at the Ruhr University in Bochum, and a senior consultant and scientific coordinator of the Rheumatology Center in Herne, Germany. Also joining me today are Dr. Sofia Ramiro, a consultant rheumatologist and senior researcher at Zuiderland Medical Center and Leiden University Medical Center in the Netherlands, as well as Professor Hideto Kameda, professor of internal medicine at Toho University. And of course, if you want to find out more about us and the papers we are discussing today, please head over to the CSF website, that is www.cytokinesignaling.com. Time to hand over to Professor Kameda.
Okay, thank you, Atul. Our first paper aims to determine when the optimal time to start secukinumab treatment is demonstrated by a significant difference between baseline and post-treatment BASDAI scores. Our second paper that goes on to evaluate a case report of a 45-year-old male with ankylosing spondylitis and adalimumab-induced refractory paradoxical palmoplantar pustulosis after failure of prior secukinumab treatment. Over to you, Sofia.
Thank you very much, Hideto. So our first paper is entitled When to Start Secukinumab Treatment in Patients with Axial Spondyloarthritis Before or After Anti-TNF Treatment. As we know, secukinumab has demonstrated efficacy in axial SPA in randomized controlled trials, the Measure 2 and the Measure 3 trials. And previous data from RCTs has thus allowed to conclude that secukinumab was more efficacious in TNF inhibitors naive patients than in TNF inhibitors experienced patients. But actually, there is little data from daily clinical practice in which patients are not selected as they are in randomized controlled trials. So the aim of this study was to evaluate the efficacy and safety of secukinumab in patients with axial SPA in both TNFI naive and TNFI experienced patients in daily clinical practice. This is a retrospective cohort study that consisted of 84 patients who were analyzed, stratified for the TNF inhibitor exposure. 22 patients were TNFI naive and 62 were TNFI experienced patients. BASDAI was assessed at baseline and after treatment. Treatment began with an initial loading dose of 150 milligram of secukinumab weekly for 4 weeks. If no response was obtained at 4 weeks, then treatment was stopped, assuming a primary failure. After week 4, the remaining patients were continued on secukinumab, along with their BASDAI assessments that were monthly performed. And if at week 24, no response was obtained, then patients were considered as having a secondary failure and secukinumab was then stopped. And the treatment with secukinumab was considered for the remainder of the patients and up to week 52. And these patients were still on secukinumab till the primary endpoint of this study. And now up to the results of the study, we have a group of patients that were TNFI naive and patients who were TNFI experienced, and they were largely similar, though with a longer disease duration and more peripheral arthritis in the TNFI experienced group. In the TNFI naive patients, so 22 patients, 27% of the patients had a primary failure, another 27% a secondary failure, and no patient stopped treatment due to adverse events. So at week 52, slightly less than half of the patients were still on secukinumab. If we look at the TNFI experienced patients, so there were 62 patients, 29% had a primary failure, 15% a secondary failure. So that means that at week 52, we had still more than half of the patients on secukinumab. And if the BASDAI before and after treatment was compared, there was a statistically significant difference between the BASDAI score before and after treatment. And this was both for the TNFi in naive patients with a change from, at a group level, from 6.2 to 4 in BASDAI, and the TNFi experienced patients with a change from 6.1 to 4.2. No major safety issues were reported. There was one discontinuation due to uveitis, another one due to alopecia, and one due to a recurrence of pneumonia in an older patient. So in conclusion, this study confirmed the safety and efficacy of secukinumab in both TNFi naive and TNFi experienced patients in daily clinical practice. And I think it's important to realize that actually knowing data from studies and using these drugs in daily clinical practice, there's a need to understand the effectiveness of treatment in daily clinical practice, and that's where we see this type of studies coming up, which is relevant. On the other hand, I think we all acknowledge that there are limitations when we do not have a comparator, which was the case of this study being only a retrospective study without the comparator group. So I think it's important to always try to have a comparator. And that brings us, on the one hand, trials, randomized controlled trials, are the optimal setting when assessing the efficacy of treatment, as we have a controlled setting and we have a comparator and patients are randomized. We want to move to daily clinical practice and have patients that are representative of our daily clinical practice, not selected as they are to trials. But it's important to not only have a comparator, but then to think about confounding by indication when we try to compare patients, because of course, in daily clinical practice, there is a reason for which a rheumatologist chooses for one treatment and not the other often. So those are aspects that need to be considered, which makes this type of studies challenging, but therefore very relevant. So I think that this highlights that especially after failure of a TNF inhibitor, it's not clear which is the best mode of action to follow. Also, in the beginning, even before TNF inhibition failure. And I think we need more studies to address this unmet need. What do you all think?
Yeah, thank you, Sophia. I mean, I think this is quite a sobering paper. I mean, I understand there are limitations when this is not a study, sort of prospective study. This is a retrospective analysis of their experience. And you already mentioned that the anti-TNF inadequate responder population, they already had a longer disease duration. They probably, these are the types of patients which I find they're a little bit older, they have got longer disease duration, they have other comorbidities, they have failed one drug, and these are difficult to, bring under control, their disease to bring under control. What is interesting to me, sobering statistics here, and of course it's a slight difference, but TNF inhibitor naive patients, more than 50%, slightly more than 50% had dropped off by 52 weeks, whereas TNF inhibitor inadequate responder, about 45%. So it is kind of sobering that we still don't know who is the ideal patient. And when we see a patient in front of us in the clinic, should we start them on TNF inhibitor or should we start them on IL-17 inhibitor? We don't have any biomarkers. And we currently, in the US, we use according to what the insurance company would approve. I don't know the situation in Netherlands or Germany or Japan, but we are mostly guided by other things, not really knowing which patient will respond to what, rather than the biology. We consider other things, what is convenient, what is available, etc., etc. And that's quite sobering. We certainly need biomarkers in this situation as to decide which patient will respond to what treatment.
Yeah, I agree with you. I think biomarkers would be ideal. I think history also tells us that it's quite challenging to find additional biomarkers that make it up to our daily clinical practice. So there's a lot of research going on in that field, but unfortunately, an important part of it ends up disappointingly not bringing new biomarkers to our daily clinical practice. I think the other part that can help is if we have head-to-head trials in which we obtain more knowledge than the current mostly placebo-controlled trials. So I think it's a complement, and in several ways we can increase our knowledge about which is the optimal treatment option for each patient.
My experience is slightly different, that this more than 50% patients for TNF inhibitor, so TNF inhibitor naive patients, more than 50% at the end of a year don't stay on IL-17 inhibitor. That is not my experience. And I think maybe because we almost always start patients at 150 milligram of secukinumab and then jump up to 300 very quickly. And I'm not sure that they did that in this particular study. And then I'm able to keep certainly more than 50% of the people on secukinumab at the end of a year if they are TNF inhibitor inadequate responder. That actually has stuck with me with this study. That is quite surprising.
To me as well, and I think that emphasizes the limitation that I started by mentioning. We don't have comparative data, so it's a description of what happens, of a finding in a cohort, without being able to compare it to other modes of action. So I think that's very important when we go to cohort studies. I think having a comparator is very important.
Xenofon, do you have anything?
Well, I don't have anything to add. I was thinking of a similar study that was published with the other IL-17 inhibitor that we have with Ixekizumab. Published means it's still in abstract form as far as I'm aware of, where they did a similar analysis. And they found out that 1 out of 4 patients who have been pre-treated with TNF blocker and was not responding would then respond to IL-17 inhibition. So it's not only the level and the, let's say, the magnitude of response, but also if there is any response at all, let's say measured by AxSpA and so on. But it brings us back to what you all both mentioned. Who are these patients who we should start with the one or the other treatment? On the other hand, so we don't know that. I don't have anything to add so far. This is all idea generating, I think, but we do need a prospective study. The other thing that I am concerned about in this kind of analysis is whether or not we're just measuring, a one-time point outcome. Yeah. Although there is, of course, over the period of a couple of months or a year, there is fluctuation of this activity for many different reasons. And, these studies need to have a one-time point decision. So it might be that we just don't capture enough, or we just capture too many patients who are or not non-responders. So this is daily practice, but as Sofia also mentioned, we need more information. And you said that also the situation is unclear.
Hideto?
Yes, as Sofia mentioned, the limitation of this study includes only 22 patients with TNF naive was included. So the comparison is very, very limited. And also it is very important which TNF inhibitor was used for TNF experienced patient, and how was the dosing and how was the outcome. Those information is very, very important for our very precise analysis of the study results. Thank you.
Yeah, thank you. Thank you all. Xenofon, do you want to discuss the second paper?
Yeah, sure. We can go over to the second paper, which is called A Patient with Adalimumab-Induced Refractory Paradoxical Palmoplantar Pustulosis was successfully treated by Ixekizumab, a case report. So we see here again situations where we have TNF blockade versus IL-17 blockade. The patient overview that is now being presented in this case report is a patient with who is male. He's age 45 with no history of psoriasis. And the background of this story is that TNF blockade is associated with paradoxical adverse events. So the situation here in this case report is whether or not we are able to draw any conclusion or knowledge on that matter. So that male patient, again, he's age 45, no psoriasis in the past, presented after 6 months of adalimumab treatment with painful eruption of pustules in both palms and soles. A scalp plaque on his scalp and the left lower limb, and the palmoplantar pustulosis area severity index score of 26. Adalimumab treatment was stopped. Secukinumab 150 milligram was administered the way we know it, 2 weeks in the beginning, and thereafter they increased it to 300 milligram. So in that particular case, it was 0, 2, and 4 weeks, and then 300 milligrams. And after 3 months of secukinumab, the lesions still did not improve. And of course, that may bring us in daily practice in the situation that we have to explain ourselves to the patient what is happening, and of course try to find out what the right treatment of the patient is. Now, in this case, the patient was started with Ixekizumab 160 milligram, and then he got the maintenance injection of 80 milligram every other week. The baseline PP PASI, the paradoxical palmoplantar pustulosis severity index prior to Ixekizumab was 26. After 3 months, the score improved down to 10. The lesions and the pustules on the palms and the soles improved as well. They are being included in the score. And after a patient's 10 months follow-up, the paradoxical psoriasis was in complete remission. So in conclusion, the authors say that in a TNF inhibitor-induced refractory paradoxical palmoplantar pustulosis, IL-17 inhibition, in this case with Ixekizumab particularly, should be considered as an alternative option. And of course, the question is how or what kind of knowledge we gain out of this, and how we would deal ourselves with such a situation in daily practice.
Yeah, I have had experienced this situation quite a few times with TNF inhibitors in the past. And the dermatologist at my center, they generally call this psoriasiform dermatitis rather than calling it psoriasis. This is TNF-induced psoriasis-type lesions. And the dermatologist at my center, they somehow differentiate between psoriasiform dermatitis and psoriasis. Be as it may, this is quite typical that this type of psoriasis is this palmoplantar pustulosis, which is quite distressing to the patient. And interestingly here, it's not just TNF inhibitor, but it's not just IL-17 inhibitor that worked, but one worked and the other did not, which is also I find it very interesting that Secukinumab didn't work, but Ixekizumab did work. I have had one patient, maybe two patients, now that I think about it, who in fact developed this problem on Secukinumab as well. So this palmoplantar pustulosis is not just restricted to TNF inhibitors, but also seen with IL-17 inhibitors. And recently, in fact, I was looking at Bimekizumab data, IL-17A and IL-17F inhibitor. And there are, if you look at the 52-week data, there are less than 5%, 2-3% of the patients had pustulosis. So it's very interesting, and I don't know the mechanism behind this, how TNF inhibitors would cause this, and even IL-17 inhibitors might actually cause this, and I got no idea what to do if there is so the two patients that I had who developed this, I sent them to dermatology, and they were treated with creams and lotions and potions, and I put them on JAK inhibitor, and they all responded. So this is not restricted to this phenomenon of palmoplantar pustulosis after biologics is not just restricted to TNF inhibitor, but also seen with IL-17A and now also A and F inhibitor. I don't know.
I believe we learned two things out of this case report. First of all, these things can happen.
Yeah.
Need to be prepared. And secondly, it does make sense to even circulate within the drug class of IL-17 inhibitors, something we knew already before in the TNF blocker area. Well, obviously, this is a pretty dermatological, or more, goes to the dermatological side, and might not be seen so frequently in our area, but obviously you had some similar cases as well. But it does make sense to think about circulating within the drug class before we decide on the final treatment.
Yeah, important. Yeah. Professor Kameda, do you have any experience like this? Have you seen this?
Yes. Also, my patient shows a hair loss. So that was a very big concern. And also in Japan, an IL-23 inhibitor, Ixekizumab, was approved for palmoplantar pustulosis. So I wonder that how about the IL-23 inhibitor for such kind of patients?
Yeah, this patient had axial SPA, right? So it will be kind of, I mean, I guess to treat the palmoplantar pustular psoriasis, one can use IL-23 inhibitor, but then the underlying disease may not be treated in that situation. Sofia, do you have any comment on this?
No, just I have the experience with TNF inhibitors. I never experienced this with IL-17 inhibitor, and I think it's important, as Xenofon mentioned, to see that even if in one IL-17 inhibitor it doesn't work on this, we can try another one. But and I think we know more that from TNF inhibition it's more a class effect. So I would be more inclined after TNF having such an effect on TNF inhibition to try another TNF inhibitor, and as an alternative to a different IL-17 inhibitor is also a JAK inhibitor, as you mentioned, Atul.
Yeah. Thank you. Thank you all for joining, and thank you, the listeners, for joining us today for this AxSpA podcast brought to you by the CSF. We really hope you found it useful. And if you did, don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcast from, so that you don't miss any future episodes. If you want to read more about what we have discussed today, head over to cytokinesignaling.com, where you'll find detailed summary slides of each of the papers. See you next time. Ciao.